Mr. Doe, is it? Hi, my name's Sierra Dow, and I'll be your PA today, so excuse me just a second, I'll wash my hands. Okay, so if you could just confirm your name and date of birth. Okay, and I'll check your hospital bracelet. Okay. So I see you're here for a male exam, so we'll just go ahead and we'll get started. I first just would like to state that throughout this entire exam, I'll explain the whole procedure as we go. I'll remain gloved. We'll drape you from your chest to your abdomen. And for this exam, the patient will be standing throughout, and I will be in a seated position. So first, we'll just begin by inspecting the skin, and like I said, the patient will be standing. So we're just looking this around. So we're just looking at the skin, looking for any lice or nits that might be present at the base of the pubic hair. Then I'll be inspecting the prepuce, and so I would do this by retracting and then replacing the foreskin if there was any, or if the patient was more comfortable doing this themselves, then we would let them do it. It should be noted that this is essential because it checks for chancres or carcinoma. After that, I'll inspect the glands and the meatus, so I'm just looking for any ulcers or nodules, scars, inflammation, tenderness, anything like that. And I'm also checking out the location of the meatus. Then I would move on to palpating the glands in the meatus. So I'll take my thumb and my index finger. I would just compress the glands to open the meatus and check for any abnormalities. After that, I'll be taking my thumb and first two fingers, and then I'll be palpating the shaft of the penis, checking for any induration or tenderness that might be present. And it should be noted that this is often excluded or not done in younger patients or those that are asymptomatic. Okay, so now for the next portion, we'll just move on to inspecting the scrotum and its contents. So first, I would lift up the scrotum to check the posterior surface, and I'm looking for any lesions, nodules, scars, veins, anything like that. Then I would just inspect the scrotum and its contents, seeing if there's any lack in development of the scrotum in either one or both, which would be suggestive of cryptorchidism, or if there's any scrotal swellings, and then that could be suggestive of an indirect inguinal hernia or a possible hydrocele. So now we'll move on to palpating the scrotum and its contents. So first, I'll just begin by palpating the epididymis, which is located on the superior posterior portion of the testicle, and this is nodular and cord-like. Then I would move on to palpating the testes and the epididymis, checking with my thumb and finger, and I'm just checking size and shape, nodules, consistency, tenderness, induration, anything like that. And then after that, I will palpate the spermatic cord, including the vas deferens, with my thumb and fingers once again. And I'll start at the epididymis, and then I would work my way up to the superficial inguinal ring. For the next portion of the exam, we would darken the room. And with this, we're just going to check for transmission of lot. So I would take a lot source, if we had one, and I would shine it behind the scrotum through the mass that we're questioning and look for the transmission of a bright red lot. So this is not seen, transmission of lot is not seen in blood or tissues. So now we'll just move on, and I'll check for an indirect inguinal hernia. So with this, the patient would be standing, I would be sitting in front of them. I'm just going to take the tip of my right index finger and place it at the inferior margin of the scrotum on the right side to check for a right inguinal hernia. Then I'll take my finger and I would move upwards toward the inguinal canal and vaginating the scrotum. With this, I would then locate the external inguinal ring, which is above and lateral to the pubic tubercle, and then I would just palpate the external inguinal ring. After that, I would ask the patient to perform a Valsalva maneuver, so this could be like coughing or straining down, anything like that, and I would try and feel a bulge that would come through this inguinal canal. And then I would repeat these steps again for the left side with my left finger, doing the same thing once again. So now we'll check for a femoral hernia. So I would place my hand on the anterior thigh along the femoral canal, and I'd have the patient cough or strain. And I'm just checking for any inflammation or swelling that might be present in that area. It should be noted that a femoral hernia is located below the inguinal canal, is more lateral, and never goes into the scrotum. Okay, so now that we are done with that portion, we'll move on to inspecting the prostate and the rectum. So to begin, I would have the patient turn around, and they would lay their upper body across the table or the bed. So I'll just flip him around here. And so we're just going to begin by inspecting the sacrococcygeal and perianal areas, looking for lumps or nodules, excoriations, tenderness, inflammation, anything like that. Then I would have the patient strain down, and then I'm inspecting the anus here, looking for any nodules or lumps, anything that would be present when he performs that maneuver. Okay, so now we'll move on to palpating. So what I'm going to do is he's going to stay in the same position, and I'm going to lubricate a gloved index finger. Okay. And I'm just going to ask him to strain down, and I'm going to place the tip of my index finger towards the umbilicus. Okay. So I'm placing my index finger towards the umbilicus, not going all the way in, just noting the external sphincter tone. So now I'll insert my finger all the way to its full length, and I'm just going to palpate the posterior surface of the prostate, noting the lateral lobes and then the median sulcus. And I'm checking for any nodules or inflammation, lesions, tenderness, anything that would be abnormal during this. So after I complete that, I'm going to rotate my finger clockwise and then counterclockwise, and making sure to palpate the entire rectum. And once again, I'm just feeling for those same things. If there's a lesion or tenderness, any swelling, anything like that. And if I did find a lesion or something, I could have the patient strain down to bring that lesion closer to my finger. Okay? So after that, I'll remove my finger. I would give the patient a tissue to wipe their anus. I would note the color of the fecal matter on my glove, and then I could also test for cold stool. Okay. So that completes our male exam. Do you have any questions? Okay, thank you so much.